Hello, thank you for the opportunity to speak to you today about the early findings of my study, which was carried out in fulfilment of my PhD. My name is Stephanie van Eeden, and I'd also like to acknowledge my co-authors on this study, Helen and Cristina McKean, for all their help and support and advice, and for being great supervisors for my PhD. The study was funded by the National Institute of Health and Care Research in the UK. It is well documented that children born with cleft palate, with or without cleft lip, are at increased risk of speech sound disorder. Despite improvements in services in the UK, a large percent are still in need of speech and language therapy on starting school, and appear not to respond to traditional methods of early intervention. Recent evidence has highlighted poor academic achievement in this population and lower language levels, especially in the early years. Focus for speech and language therapists working in cleft centres remains with speech outcomes, and there has been little evidence about the relationship between speech and language. Moreover, no studies have compared children with cleft palates to other children with speech sound disorder. So we do not know if children with cleft are indeed at increased risk of both speech and language disorder, or if they present with similar profiles for those with speech sound disorder. This picture shows an isolated cleft palate. It is the cleft of the palate that causes speech difficulties and not the cleft of the lip, although many children are born with both cleft lip and palate. Clefts of the palate are usually repaired between 6 and 12 months in the UK. The aim of primary surgery is to achieve good velopharyngeal function, leading to normal resonance and a structure which allows for typical development of speech sounds. Ongoing palatal problems can lead to disorders of resonance and articulation, where errors develop in order to compensate for a faulty velopharyngeal mechanism. For this reason, cleft speech disorder has commonly been thought of as a structural articulatory speech difficulty. The Cleft Language and Auditory Skills Study was started in 2018. We gathered data on speech, language and listening skills in children with non-syndromic cleft lip and palate and a control group of non-cleft children with speech sound disorder. The study described in detail the skills in each of these areas and sought to look at the relationship between them. Today I will focus on the language skills and how they relate to speech, and present some of our early findings. I will present the early language results from two studies. The first was an observational cross-sectional study of 95 children with non-syndromic cleft palate with or without cleft lip. They were aged between 5 and 8 years old. The second was a matched case study of children the same age. 10 children from the main study were matched to 10 children from the control group of children with non-cleft speech sound disorder. In both studies, speech was assessed using the DEEP. This allowed for percent consonants correct and normative data. It also allowed us to group the participants by diagnostic subgroups, which will be discussed a bit later. Language was assessed using the CELF-5. This gave us receptive and expressive indices and data on specific skills assessed by these subtests. Sentence comprehension assesses the ability to understand grammatical structures with increasing difficulty by matching a spoken sentence to one of 4 pictures. Word structure assesses the ability to use grammatical markers, including plurals and tense. Word classes assesses semantic knowledge by asking to identify which words go together the best. Following directions assesses ability to follow instructions of increasing difficulty through length of instruction and ability to understand common concepts such as first, middle, before and after. Formulating sentences assesses the ability to use a given vocabulary item and to describe a picture. Understanding the word and the context as well as the use of correct syntax is assessed. And finally, recalling sentences assesses the ability to repeat back exactly a spoken sentence. This measures auditory memory and is commonly used to reflect incorrect or delayed internal linguistic structures. So, in study 1, we looked at 95 children with non-syndromic cleft lip and palate. Most of the children were aged 6 and so had been in school for at least a year. The distribution of cleft diagnoses was representative of the wider population. There was almost an equal split of girls and boys, and in line with other data, 61% had a history of hearing difficulties. Children in this group had an average percent consonants correct score of 86%. There was the expected number of children presenting with cleft articulation errors known as cleft speech characteristics or CSCs. But there was a surprising number who also presented with developmental errors or phonological delay. Surprising because this aspect of speech development is often overlooked due to the presence of cleft errors, which are considered more severe and less likely to improve with intervention. However, reports in the literature would suggest that this high level of phonological delay is not unusual in children with cleft palate. This slide shows the results for the whole group for receptive and expressive language indices. As you can see, they are not far from the normative mean of 100 and reflect what has been reported in the literature. This slide shows results from the subtests. Again, group scores fell well within one standard deviation of the norm mean of 10. Use of grammatical markers seems to be a strength. Formulating sentences was consistently the most difficult subtest, and further work investigating the specific skills for this subtest is needed. So far, it looks as though we needn't worry about the language skills of the children on our caseload. But there was a wide range of results, with some children falling low enough to warrant a diagnosis of developmental language disorder. In total, over 24% of scores were below one standard deviation, which puts them at risk of persistent language problems. This has huge ramifications for academic achievement and later life outcomes. This slide shows the receptive and expressive language indices, but the same pattern was seen for the subtests, with an alarming 40% falling below one standard deviation for formulating sentences. So who are these children that are at risk of ongoing language difficulties? Here's a reminder of the types of speech errors seen. The deep assessment determined 4 diagnostic subgroups: typically developing speech, articulation disorder, i.e. significant CSCs only, phonological disorder, i.e. developmental errors outwith the age expected to have grown out of the error, and a combined phonological disorder with CSCs. Data was analysed to examine the relationship between the pattern of speech development and language outcomes. This slide shows receptive and expressive language outcomes by those diagnostic subgroups. For both these measures, we see the impact of phonological delay or disorder. There were no differences in language outcomes for children presenting with CSCs or articulation problems only, and those with typically developing speech. Significant differences were seen between those with typically developing speech and those presenting with phonological disorder with or without concomitant CSCs, and the group with a combined speech disorder scored the lowest. This pattern remained the same across all subtests, with formulating sentences again at the lowest level. Indeed, as a group, children presenting with any developmental speech errors were seen to struggle with this skill. So this study corroborated findings from the literature that children with cleft palate on average have language skills within the normal range. However, there were many outliers and some specific deficits observed which need further analysis. More importantly, the proportion of children seen with phonological difficulties would suggest a larger than expected group of children with cleft palate who do have a level of underlying linguistic deficit, and the impact of these difficulties, if undiagnosed, on progress in therapy and in school can only be speculated. For study number 2, we conducted a small matched case study comparing children with speech disorder and cleft and those with speech disorder without cleft. The cleft group were taken from the same cohort as study number 1. The control group was recruited from local SLT services. Groups were matched for diagnostic subgroup, for percent consonant correct, for age, for gender, for socioeconomic status, and history of hearing problems. The same assessments were used as for study number 1. This slide shows the results of the Receptive Language Index. A Mann-Whitney U test showed a significant difference between these two groups, with the children with cleft palate having significantly lower scores for understanding of language. This slide shows the results for the Expressive Language Index. Scores were lower for the cleft group, but no significant differences were seen. And this slide shows the results for the language subtests from the CELF-5. Whilst no significant differences were seen apart from for sentence comprehension, the children with cleft consistently scored lower in all subtests, apart from the use of grammatical markers as measured by the word structure subtest. This was a very small study, but no other research has compared children with cleft palate and speech disorder with non-cleft peers with speech disorder. The results from this study would suggest that further investigation is warranted. In summary, findings from these studies have highlighted a group of children with cleft palate and developmental speech difficulties who may also be at risk of longer-term language difficulties. The focus of cleft teams remains on articulatory constraints as a result of the original structural defect, and sits therefore in the diagram here very firmly in the yellow section. However, ignoring developmental speech delay could be detrimental to helping our children reach their full potential in those vital early years of education. It is important that speech and language therapists are aware of this link and that some children overlap with the peach area in this diagram. It is essential that appropriate assessment and intervention is carried out. It may also be that cleft children are at even more risk of persistent language difficulties compared to their non-cleft peers with speech sound disorder. The reasons for this are not clear and are likely to be multiple. Children with cleft palate will have had several hospital visits and general anaesthetics in their early years. They have a high level of conductive hearing loss. Some studies have shown differences in parent-child interaction, and expanding work in genetics may help broaden our understanding of how some yet may fall into a diagnosis of language disorder associated with another biomedical condition. These observational studies have shown that all areas of speech, language and communication on this catalysed model need to be considered and assessed for children who are born with cleft lip and palate. Thank you for your attention and for listening to this presentation today, and thank you for your interest in these studies.